I'm Dr. Gary Ansel. I'm the Assistant Medical Chief for Vascular at Ohio Health Riverside Hospital in Columbus. And I'm really happy to have beside me the Chairman of the Division of Cardiology at the University of Toledo and my old partner, Mark Burket. It's been a long time, Mark.
Yeah, it has.
What is it like being here now, 11 years? Has it changed?
Well, it's always been a privilege, and it's really changed a lot. I still remember the first phone call that I got from Krishna Roka Singh describing what the VIVA concept was, that it was really going to be an effort to be a truly educational conference, not just a show and tell, and that it was really going to be multidisciplinary. And I think those themes have really carried on through all the years, but what's changed is it's become bigger. I think there have been a lot more creative ways of teaching and interacting with between the faculty and the attendees. A lot of fun in the process of learning.
Well, speaking of creative, I think one of the things that we like is the fact that you somehow always give some of the most creative talks. And now, especially being division chief, the economy of medicine is probably front and center in your vision as you go down the road. And in fact, this year, you're going to be talking about the economics of patency and restenosis and retreatment and those kind of things. Is that really working is it really playing a large part of your everyday life?
Well, I think these are things that we have to address, and what I'm finding is that as I've started to do research on the economics of SFA intervention, I'm personally much more conscious of how much I'm spending to do a case. Before I started looking at this, I had no idea what some of the stents cost, what some of the balloons cost, reentry tools, crossing tools. And as you start to look at those costs and then see what the hospital receives to do the procedures, you start to realize that we've got to start changing our practices, or else the wheels are going to fall off. We aren't going to be able to continue doing what we're doing right now.
Right. I think even in Columbus, in our own life, one of the things we focused on very early on is sometimes we call it wastage, but I think it's, we always want the perfect wire, the perfect tool, the easiest time. Have you guys had that focus as well, trying to adjust on that yet, or where are you at with trying to do the economy of scale right now?
So what we're doing right now is we're trying to educate the consumers, the docs, as to how much things cost. And right now it's been fairly informal. We'll have a conference in which the interventional docs and the support staff in the cath lab are simply instructed about how much a certain stent costs or an IVC filter. And so the next time they do a case, they realize, well, we can use this one for this cost or this one for 2.5 times as much. They do about the same thing. And so right now it's kind of a voluntary compliance thing. But I think docs are, for the most part, motivated to do the right thing. Right. And so it helps to, when you get that education, then you can make a good choice.
Yeah, I think that's neat. I think even the docs and the techs, sometimes like if a wire, hits the ground, sometimes you make the comment, well, there was another $180. Yeah. It just puts a different emphasis on what's going on and where things are heading. So are you changing any approach with the vendors right now, as far as, the Cleveland Clinic has talked about restricting vendors to certain ones that have to meet certain price thresholds and limiting the number of different industry folks that are in their labs. Has the University of Toledo made any of those kind of changes as well?
Yeah, I think one of the big changes that the university made was to initiate the VAC, or the Value Added Committee, which creates a barrier for any new products, regardless of vendor coming in. And then within that context, if a new product is being considered to be on the shelf, the economics enter in right away. So we may be able to bring in a stent if it's equivalent but cheaper. Mm-hmm. For example. So some of those decisions are being made right now. We so far have not really restricted vendors in the vascular arena. We have made some moves like that in the EP world, the electrophysiology world, with mixed results.
There's that cost of the procedure itself, and it's somewhat, at least, I don't want to say easy, but it's certainly a lot more focused on being able to figure out what the cost of that procedure ends up being. As you said, it's got to be certainly brought down. But as we go through, the changes in medicine that they're talking about with, restructuring and being more socialized and needing the valued medicine, How are you guys starting to approach the cost of care at the, say, 6 month, 1 year, or whatever mark? How are you making moves towards that direction, or how do you think that'll happen in the future?
Well, I think those changes are going to absolutely have to happen, and that's really an important question. Right now, there's this incredible disconnect between financial incentives. So the hospital is motivated to make each procedure profitable, and then to do as many profitable procedures as possible, and to do no money-losing procedures. On the other hand, the healthcare payer, whether it's Medicare or insurance, is really interested in keeping costs down over the long term. And those two motivations are not the same. And I think as we go forward, there has to be an alignment of those incentives. I think one of the things that becomes very obvious in the femoropopliteal segment is if you look at drug-eluting balloons and stents, there's an increased cost up front. The hospital pays that, but there's a decreased cost of intervention down the road, and the payer benefits from that. So it's, these incentives aren't aligned, but they really need to be in the long term.
Well, that would be great points, because I think that, you know, it's also a patient satisfaction standpoint, knowing that they're going to be maybe free from coming back for as many procedures, and maybe a prolonged freedom from their symptomatology and things like that. So, you know, as you're going through this process and you're trying to really ferret this out, what kind of data are you, as the University of Toledo and your division, starting to utilize to make those decisions?
So what we've simply done is to take a sample of patients who have had femoral interventions, and these typically have been in a research trial, so we have access to all of their follow-up data. And within the hospital, we have the ability to calculate what the cost of a hospitalization is, not what the charges were, which are inflated, but the actual cost. And so we can take the cost of a first intervention, we can compare that to a subsequent intervention, and then we can compare it to those patients who really have a complicated course with multiple interventions. So far, I think the only thing that has really impacted is it makes me more willing to do an expensive procedure up front. And so if I'm comparing two different strategies for treatment, one being very expensive and one not so expensive, if the more expensive one has a lower rate of target lesion revascularization, it's worth it, and I'm more inclined to forget about the initial cost and do the best treatment up front.
And finally, let's go on a whole different type of approach, because we've got the hospital looking at its costs, the insurer looking at its costs, the docs looking at how much they're spending. So what about the consumer? We've got a whole new type of payment system coming to the United States. Do you think we're going to, are you already experiencing, or do you think we're going to see a new emphasis on the consumer being more educated about the cost of the procedure and what it means to them long term?
Well, we're already starting to see some of that with the self-pay patients, and I think as people have higher and higher deductibles going forward, which really seems to be an increasing trend, at least in our area of the country, I think they will be very concerned about what does this cost now and what does it cost later. So I think we are seeing those changes early on. I think we're going to see a lot more. Well,
we've come a long way since 1994, when I left to go back down to Columbus after you helped train me, and I appreciate the ability that you've given me to get where I am, and to be able to now interview my mentor is quite a privilege. So thanks, Mark.
Well, it's a privilege to have this opportunity to speak with you, and I've always enjoyed our friendship most of all, so
Absolutely.
Thank you.
Thanks.